Hi there, I'm Stephen Shepherd. I'm one of the consultants in intensive care and anaesthetics here at Barts Hospital, and today I'm going to talk to you through the difficult airway trolley and the use of the CMAC video laryngoscope. So the first thing to say is hopefully those of you who are anaesthetists will be familiar to the concept of the difficult airway trolley, but there are units on every one of the intensive cares. There are 2 within theatre, and there is 1 in the catheter lab, which is based in lab 10. If you need it. The layout follows the DAS algorithm for unanticipated difficulties during tracheal intubation. And as you can see, you've got 4 drawers: Plan A, Plan B, Plan C, and Plan D. Copies of the algorithm are attached to every one of the trolleys, and you'll also find on there usually a monitor to be used with our ambuscope, which is the scope that we use for both bronchoscopy and awake fibre optic intubation. The thing to say is we don't really have a head and neck cohort in this hospital. We do have some patients on the 5th floor who are receiving radiotherapy for head and neck cancers, but they are the minority. So in general, people who run into problems with intubation are going to have what we'd call non-pathological reasons for that. So there will be your kind of larger patients, people who have difficult kind of anatomy because of big tongue or kind of protruding breasts, but in general you'll be able to manage with the kit that's there. We don't really have people who have facial trauma or facial cancer in the main, although we do have a very small number of those patients in hospital. So you'll see that the trolley is sealed. If you break the seal, you'll be assured that it's checked, and there's a checklist on the top of it, and we'll go through each one of the drawers and thing. So in the top drawer, you've got standard endotracheal tubes and Macintosh blades. So we've got a selection of tubes. We've got a 6, 7, 8, and a 9. We've got 2 laryngoscope handles, which come as the disposables, and we also have blades, a Mac 3 and a Mac 4. All of these can be used for direct laryngoscopy in the majority of cases. We also have here 2 McCoy blades in a size 3 and size 4. So these might be helpful for those patients who have an anterior larynx or in whom you might wonder about using a bougie. Sometimes that can make life slightly easier. But again, if you're not familiar with this, please come and talk to me or any of my colleagues and we can give you some training in it. We also have available 2 air tracks. Again, these are not part of the standard algorithm for Plan A, but if you would like to be shown how to use them or you're unfamiliar, again, please come and talk to me. But essentially these are a form of indirect laryngoscopy with a pre-mounted channel and a light. And again, they come in a variety of sizes. So in Plan A, you'll generally find everything that you would need for your first attempt at direct laryngoscopy. If you fail at that, and the guidance suggests that you have 3 attempts doing something different every time, or a further 1 attempt with a change of operator, then you need to move on to Plan B. So Plan B is declaring failed intubation. That's fine. So your immediate rescue strategy should be to place a supraglottic airway. And it's recommended that you place a supraglottic airway that can potentially be intubated through by a more experienced operator. So in practice, this means a standard LMA, an LMA Classic, or an iGel. And if you open drawer 2, you'll find options for both of those. You'll see that we have iGels in sizes 3, 4, and 5. So 3 for a smaller person, 4 for most women, 5 for most men. Again, if you're unfamiliar with this from an intensive care environment, come and talk to us and we can arrange some training in theatre for you. You'll also find same 3, 4, and 5 with a Pro Seal and a 3, 4, and 5 of a standard laryngeal mask airway. Again, training can be arranged for these. If you're unable to maintain oxygenation by use of a supraglottic airway, your next step is to then move forward to try and use airway adjuncts using hands and bag mask ventilation. So in C, you'll see that you have a range of oropharyngeal airways. So again, a size 2, 3, and a 4, or a green, orange, red. And you've also got nasopharyngeal airways, a size 7 and a size 8. We also have larger masks. So we have a size 5 mask, which is a red for those people who are particularly large. but also replacement masks if needed for whatever reason. If all of those things have failed, then the next step is emergency front of neck access. So having declared an emergency, sought help, you should move on to this step pretty promptly. The preferred front of neck access is to use a scalpel and a bougie, so where you can feel the cricothyroid membrane, have a feel, make a transverse incision, place a bougie, and then apply, say, 6 endotracheal tube through that, which is well lubricated. Again, we can arrange drills for this, those of you who aren't familiar, and we run these about once every 6 weeks or so. We can certainly also arrange drills in theatre if you feel you need more experience. This is a very rare event, but it is something that can save lives if you move forward to this step. And you'll find everything that you need to do it in the bottom drawer. So you've got a scalpel, front and neck access kit, a bougie and a blade, which basically all you need. There's also a cricothyroidotomy kit for those people who are trained in its use and who may be more familiar. Unlike other sit-ins, we also have in the bottom drawer a manujet, and the reason for this is we have a relatively high proportion of thoracic surgery, and occasionally those people need use of a rigid bronchoscope with a manual jet ventilation. Again, this is not something that's standard practice, nor we would expect it of anyone without training, but we do a lot of rigid bronchoscopy in theatres, and you'll hopefully pick it up then. But again, we're always here to help. We have a variety of bronchoscopes available for use, and our preferred system is the ambuscope system. So this requires a screen, and you'll find these dotted around quite a large number of theatre complexes, but particularly the thoracic theatres, which are 2, 3 and 10. You'll also find them in Theatre 7, which is our emergency theatre, and you'll also find them on every one of the intensive care units. Essentially, this uses a disposable ambuscope, and again, we have 3 sizes on this site. So we have a grey, which is a slim ambuscope, which is best suited for fibre optic intubation. We also have green and amber ambuscopes, which again are disposable. The amber has a bigger working channel, so is generally the best option for flexible bronchoscopy, where you need to do suctioning or tracheal toilet. And the green is a kind of in the middle, so it can be used for diagnosis, but has a smaller working channel and so may block with secretions if used in that setting. They're pretty easy to use. So you'll find ambuscopes on every one of the Difficult Airway trolley. You turn the machine on at the top left. It doesn't require a battery. To be plugged in. It has a battery which lasts around 30 minutes, so it will work without. And you'll see that you have disposable cable, and this goes into the side. If you look at the top, you'll see that it's blue, and that tells you which port that you need to put it in. And you can see you've got green and we have blue, and it will only go in one way. So when you do that, you'll see you get a screen picture, and you can, when you tap, adjust that pretty easily. And it's steered from the top. But again, we'll show you how to do that. So we have a single video laryngoscope in use on this site, which is the Stort's CMAX system. It too has a power supply but also a battery, so it doesn't need to be plugged in to be used, but if you see it, it should be plugged in to charge the battery. It will last about 30 minutes, and we have available 3 different handles. So we've got a size 4, which is equivalent to a Macintosh blade size 4, a size 3, which is equivalent to a Macintosh size 3, and also a D blade, or a Difficult Airway blade. And you can see, if you look at the left and you look at the right, the D blade, which is this one, has a more hyperangulated angle, and so can be helpful where the larynx is more anterior, or again, you may feel that if you were able to see it with a bougie and push it down, you would be able to get a good glottic view. What I would say is that you need to have pretty good mouth opening to work with both of these, which means that if for whatever reason that's not the case, this may not be the most use. So if you found a patient like that, and you want to consider using this, perhaps speak to one of the consultants about what the best approach would be. You turn it on up here. Again, it comes on pretty quickly, and this is your insert. So this needs to be lined up so that the posterior bit is going to lie towards the back, and you'll see it clicks in like that and you get a view. It's used like a normal laryngoscope, again, in, rotate, and again, you can use bougies or other stylets or introducers with this to get better access to the trachea. We use this quite a lot on this site, not only for standard intubations, but where there's a concern about a patient's COVID status, we would advocate video laryngoscopy in the first instance to reduce operator exposure towards virus, but also increase the chances of successful first pass. Again, any questions, come talk to me.